Alright guys, we're going to try something a little bit different. We're going to try a QuickTime audio with a screenshot. So here we go. We're going to talk about differential diagnosis of the knee. We're going to start and break it down into different compartments. So as we go along, just make sure that we're always coming back to our objectives. We're trying to synthesize our information, making sure that you can start to categorize and come up with differential diagnosis of maybe why your patient is presenting with knee pain or dysfunction. We're trying to develop an accurate prognosis then from the information that's presented. Remember, when we develop a prognosis, how do we determine this? Well, there's a lot of factors that go into that, and large in part depends on the stage of healing, but also on your patient's state as well. Are they a mover? Are they well hydrated? Are they having a good emotional state? And that will all improve outcomes in your setting. So tips. I would suggest that you, we're going to jump to the bottom tip. I suggest that you actually just listen one time without taking any notes. This will help you to really synthesize the information and possibly not have to write so furiously as we talk about these different diagnoses that we're going to go through today. When you go through it a second time, you're going to write down notes, and you're also going to write down questions you might have. You might have to go through and review your anatomy and your kinesiology, and then also stages of healing. As you're going through that, I would very much support that. So making sure that you're referencing all the different things that are out there. So we have your textbook, such as Dutton, but also there's some great websites out there. We talked about Physiopedia is a great website. Medline is a really good one. Medscape. So thinking about that, if you really want to know how to conversate with your patient, you can look up mayoclinic.com. They have some great verbiage, as Dr. Don Shaw would say, on how you can communicate at a level that your patient will understand. These are just a quick diagram to help you in how, when someone comes in to talk to you, we might start to categorize differential diagnosis. So we'll get into this in more detail, but just a real quick overview, and nothing more than really what's on the slide here. So if your patient comes in and they say that they've had a non-contact injury, so we think of our soccer players that have planted and twisted, there isn't a contact with that, we're going to maybe go towards an ACL tear. If there's a contact injury with a pop, so someone is hit from the side, we might think of more the collateral ligaments, so the MCL or the LCL. And then thinking about the meniscus tear, that can happen with some trauma, and then also a fracture. If we think about acute swelling, so we know that if there's a significant amount of swelling that has occurred, we're going to go right toward that there is some significant damage into the soft tissue, intra-articular or extra-articular area. We might also go towards a fracture, a knee dislocation or subluxation. A patellar dislocation and subluxation can also cause significant swelling. If you have a lateral blow to the knee, which makes sense for the mechanism of injury, you would indicate an MCL tear. Opposite, a medial blow to knee would be an LCL tear. Those check those two motions, so we should inadvertently understand why this makes sense. If you have a patient that complains of giving out or a buckling, we might consider ACL tear because we know that that's really important as we move into terminal knee extension, and quite possibly a patellar dislocation, and we'll get into that a little bit more. If you find a fall onto a flexed knee and or they're in a motor vehicle accident and their knees are flexed, we'll consider that they might have a PCL tear. Let's just talk about anterior knee pain to start with. They were going to categorize these in different areas. We talk a lot about that. You're going to be able to pick up on differential diagnosis just based on where they fit into their age spectrum, and whether they're male or female, does that increase their incidence of certain knee pains. So we think of adolescents to adults. So adolescents, we're going to think junior high, high school, and then all the way through adulthood. We're going to consider patellofemoral pain syndrome, patellar tendinopathy, patellar instability / subluxation, possibly Hoffa's fat pad syndrome, and a quadriceps contusion. For the last two, Hoffa's fat pad syndrome and quadriceps contusion, you're going to reference Dutton for a more thorough discussion on both of those. For our discussion today, we're going to focus on the top three. When we think about surgical, we can think about a trauma dislocation because we might have an avulsion that takes place. A patellar fracture, so actually, sometimes that patella can have a small fracture or it can actually shatter. And then extensor mechanism tears. So Dr. Linville will dive into that a little bit more. Elderly, we're going to go a lot towards osteoarthritis. And then pediatric, we're going to think about Osgood-Schlatter's. So patellofemoral pain syndrome. Let's just talk a little bit about what is this. It's an umbrella term that oversees pain in the patellofemoral joint and the adjacent soft tissues. Most patients will point right to their front of their knee, and they'll have pain with that. It can be retropatellar or it can be peripatellar. And it really is a result from a biomechanical malfunction. A lot of times, if you're not necessarily physically active, you're not going to get into a patellofemoral pain syndrome. It might be an overuse or an overload type of injury, but we also know that there's some anatomical and biomechanical abnormalities that can start to occur. Number one, what we would consider is a weak hip abductor and tight hip external rotators. Interestingly, a study showed in 2011 of high school running athletes. They studied over 1,000 athletes, and it showed that as someone progresses into the patellofemoral pain syndrome, that they start to lose hip abduction and external rotation strength. So we're going to consider external rotation might be tight, but it also might be something that begins to weaken over time. The foot position is very important. So we're going to originally, right away, go towards someone with more of a pes planus, meaning more of a flat foot, knowing that this will change the angle that's put on our knee and the way in which our angle of that patella tendon coming into the tibia will change. But this can also happen with pes cavus, so that high arch, because they're not able to adapt to the stresses that are being put on them. And if we kind of keep coming back to that, it's an overuse or an overload, so that load can be kind of an important part. That pes cavus is going to be more at the forefront of that discussion. We're going to see that this happens sometimes with increased Q angle. This can also be tied if they have an increased Q angle. We're going to start to correlate weak hip abductors, and then again, what is happening down at their feet. And then we're going to also look to the IT band and look at the relationship of the VMO in relationship to the VL. So studies have shown that when we have a case of patellofemoral pain syndrome, we might have tight IT bands, but also we might have VMO weakness or even atrophy, and our vastus lateralis is firing much stronger and much earlier. So that is something upon evaluation that you can actually look at, is when your patient fires their quadriceps, is the VMO latent? And if it's latent, that will help us in designing our exercise program, in which we might pick something where we're going to use a type of electrical stimulation to drive more activation of that VMO, also in conjunction with kicking on that vastus lateralis. So what does our patient demographic look like? Typically a little bit more higher prevalence in females versus males. Definitely more in a physically active population, and it's one of the most common diagnoses that we will see in sports medicine. We're going to think about this a lot with runners, that they'll have that overuse and overload syndrome. But we can also think about it with someone that is weightlifting and they're adding a lot of load going through that squatting mechanism. And if that patellar tendon is not tracking the right way, they're going to start to get some trauma into the area and have overuse with that. We also see it with some type of work environments in which there's a lot of significant kneeling and squatting. So we can identify maybe some jobs that we would see this a little bit more. One of the signs that your patients might start to tell you as the progression of patellofemoral pain syndrome goes on is that they are having pain with prolonged sitting. We would call that the moviegoer sign. They might also have pain with ascending and descending stairs, and then pain with aggravating activities such as running. Symptoms can occur during the activity, such as playing volleyball. We're going to see this with our jumpers as well. It might also occur later after the activity has been completed. Sometimes the symptoms might not manifest until later in the day. So we might just want to make sure that we have a really good discussion with our patient. Most often, though, it's going to be that they're going through that repetitive stress, and that's when it starts to come on. They're going to increase in their severity as the syndrome lengthens in time. Physical therapy is the preferred treatment for this, really to restore imbalances, correct that mechanical error that's happening, and return our patients to function. In a study done by Peters and Tyson, they looked at proximal exercise strengthening and showed that it was very effective in treating patellofemoral pain syndrome. It's published in the International Journal of Sports Medicine in 2013. Further evidence has also shown us that there is effectiveness in balancing out that hip and quad strength. So really looking at that VMO and VL contribution to how that patellar tendon is being stressed. We're also going to look and support that we need to really look at our patient's feet and discuss if they need a foot orthosis, or possibly do they need strengthening of those intrinsic muscles of the feet, and can they tolerate that? So we want to consider that. One of the longest standing practices in physical therapy would be patellar taping. There's a couple different types that we can do. We can do McConnell taping, which is using that white athletic tape to actually tape the patella in the more aligned position, and then perform exercises with that McConnell taping on. Or we can use some of our kinesio taping methods to help better activate some of the muscles around that and give support to the patella and hopefully help it track in the right way. So those are two different areas in which we can focus on. We're going to think about closed kinetic chain. An open kinetic chain tends to put more stress onto the patellofemoral joint, and especially where the insertion of that patella tendon is. So thinking about closed kinetic chain, obviously to your patient's tolerance is ideal. Proprioceptive training is key for our patient population that is going through this, because we talked already about that imbalance of that VMO and that VL and the ability to fire, and so we just want to make sure that we're really addressing this. This is where I would also start to use some of my tool-assisted manual therapy. So when you now walk away from this and you guys study this a little bit more, I want you to think about what is the treatment that you'll put in your toolbox for patients with patellofemoral pain syndrome.